Good afternoon, good morning, good evening to everybody, wherever you are in the world, to our esteemed guests here in person and online. And welcome to the event, Dying for Life, Are Mothers Still a Global Health Priority? My name is Ellen Roskam. I'm the coordinator of the Global Health Platform in the Global Health Center here at the Graduate Institute. And today we're going to delve into a vital topic, maternal mortality from postpartum hemorrhage. We have a fantastic mix of panelists today of policymakers, researchers, and health workers from the field who will share with us their insights and experience about this preventable and treatable gender-based plight. We'd like to very much thank our co-hosts for making this event possible, the Concept Foundation, the Gender Center here at the Graduate Institute, the Geneva Health Forum, and GENDRO, Advancing Sex and Gender Equity in Research. The recording for the event will be available on the Global Health Platform website in 1 to 2 days, ghplatform.org. There will be a Q&A towards the end of the event that will be open to the online and in-person audience. And for those of you joining online, please type in your questions or comments in the chat box, not in the Q&A box, including any that you want to address to an individual speaker. I'm delighted to introduce our moderator today, Dr. Claire Somerville. She is the director of the Gender Center here at the Geneva Graduate Institute. Welcome, and Claire, the floor is yours.
Thank you very much, Ellen, and welcome to you all in the room and online. We have 5 interventions, 5 contributions to today's session. I'm going to briefly just read their name and their functional title before we commence, so that we can move on quite swiftly. The biographies are available online as well, if you want to know much more about our esteemed panelists. To begin with, I would like to introduce Metin Gumezuli, Executive Director of the Concept Foundation. Next to me, I also have Femi Oladapo, Head of Maternal and Perinatal Health Unit at the WHO. Over in the far side, we have Maya Hadiati, who's a midwife who's come from Indonesia to be with us here today. And next to her, we have her translator. Thank you very much. And Shirin Hendere, who's a senior researcher at the Gender Center with us in the Gender Center, and also director of GENDRO. Finally, we will close the session with Eric Comte, who's executive director of the Geneva Health Forum, and he'll come and join us at the end. So for now, I would like to hand over, please, to Metin, who's going to give us an introduction to this field. And please, the floor is yours.
Thank you, Claire, and good morning, good afternoon, everyone. I'll just see how this thing works. So, thank you for this opportunity. I'm very happy to present on behalf of Concept Foundation. And Concept Foundation, you may or may not know about us, maybe. So we are a non-profit NGO just down the road behind the car park from here at the EPFL Innovation Park, and we have a mission to expand access to essential quality-assured reproductive health medicines and technologies in sexual and reproductive health. And as you will see in the rest of the presentations this morning, this afternoon, the issues of maternal health, contraception, safe abortion are rarely just issues of health or clinical care, but they have very strong relations with access to health care and inequities and gender inequalities. So we are very happy and proud to have our collaborations with Graduate Institute and the Gender Center here. Postpartum hemorrhage is defined as blood loss after vaginal birth of 500 milliliters or more. And this is probably one of the most preventable causes of maternal death that exists among the main killers. And about 14 million women in a year globally experience postpartum hemorrhage. And about 99% of these deaths are in low and middle income countries, although the experience of postpartum hemorrhage and the burden exists in both high and low income countries alike. So the burden in terms of having to receive transfusions or anti-anemia supplements, treatments, happens everywhere, but the deaths are primarily in poorer settings. Why do we have these deaths in 2023 still ongoing? I think there's a general lack of investment in R&D, research and development for new solutions, but also there's a challenge in not being able to conduct the implementation studies where even for those that we know that are safe and effective, getting into practice is quite a challenge. There are known quality where a number of medicines that are actually quite safe and should be effective are not manufactured to good quality standards, and that also impacts on our efficiency. And there are a number of health systems barriers that I shall maybe talk a little bit more on this slide. What we are finding is sometimes postpartum hemorrhage is seen as something that's easy to deal with because it happens just after birth, and there's usually somebody with the woman when the woman delivers, and if you give one injection or one tablet, you may reduce the hemorrhage. But there is general problems in terms of uptake of global recommendations, and often these issues are not prioritized. So the countries have their guidelines not up to date, and there needs to be sufficient political will to make sure that these interventions are put in place. And there are health systems challenges related to pharmaceuticals around efficient supply chain systems and quality issues, and some of the uterotonics that we want to be implemented are not kept in cold chain as they should be. So at our foundation, we focus on quality issues. We do quality testing and make sure that those quality standards are met. We have been involved in policy update projects in the countries, supporting countries' clinical guideline development and clinical protocols. And we have been supporting the landscaping of innovations in this space. So thank you for your attention. This is all I wanted to say to set the scene and basically try to highlight the fact that postpartum hemorrhage is an ongoing problem, and hopefully the solutions that we have will lead to reductions in maternal deaths. Thank you.
Thank you very much, and for outlining the context and also some of the work that you've been doing on this issue. We're going to have 2 rounds of questions to our panelists here. Shirin, perhaps I could start with you. I think we can clearly see to some extent that postpartum hemorrhage is a gender issue, but one that seems to have been quite overlooked. Is this still a global health priority from your perspective? Thank you.
So thank you so much. First of all, thank you so much for the invitation and for the question. we haven't done much progress in meeting the target of the SDGs, have we? So one could really justify that question, is maternal mortality still a priority? But I would also like to draw attention that we should also kind of see issues around postpartum hemorrhages and maternal mortality in the broader women's health agenda, and perhaps not only focus at that, at the pure conditions related to reproductive health, but also a broader gender issues. We know that a lot of the issues that we mentioned, Metin, of course, very articulately covered in his introductory remark, are related to the broader gender-related factors that hamper the access to effective interventions, issues related to access to contraceptives, safe abortion care, skilled health providers for ensuring that births are happening in the kind of a presence of skilled health attendants, and a broader range of issues that are necessary. We also see that there has been very little investment in research. If I'm not mistaken, during the last 30 years, there's only 2 drugs available for the prevention and management of the postpartum hemorrhages, and one could wonder why aren't there more investment in research to really try to identify perhaps more other innovations that could be more effective and more acceptable and more feasible, in particular in the context of low resource settings as well. So I think the broader issues of perhaps disconnecting the maternal mortality issues and a postpartum hemorrhages from a broader women's health agenda and gender inequality aspects as a disfavor to the topic. So I would encourage a broader and more comprehensive and also much more inclusive and participatory. I think in the whole history of maternal health, women have barely been involved in being consulted on what works, what doesn't work, issues around really overstretched health systems, overburdened health workforce, and a lot of gender issues within the health system and health workforce, which can also impact the quality of health services. There is a lot of studies around disrespect and abuse in childbirth, which is really a disincentive for people to give birth in hospitals and health systems. So really looking at that from a broader lens of gender inequality and women's health, I think would hopefully bring together a more concerted effort towards addressing the issues.
Thank you so much. And yes, contextualizing to the wider women's health agenda, I think, seems to be something that has more traction, to raise the prioritization. Thank you. Femi, if I may turn to you next. WHO recently published a multi-stakeholder commitment in the form of a roadmap to combat postpartum hemorrhage. Given the critical role of midwives in preventing postpartum hemorrhage, how were midwives involved in the development of this roadmap, and what is the role of midwives in implementing the roadmap?
Thank you very much. Thanks for inviting me, and good afternoon, good morning, everyone. To answer your question, the roadmap to combat postpartum hemorrhage between 2023 and 2030 was developed by over 130 stakeholders who met sometimes in March this year in Dubai for 3.5 days to look across 4 strategic areas that include research, guideline, implementation, and advocacy. And for this meeting to happen successfully, we set up an 18-person steering committee where we asked the International Confederation of Midwives, ICM, to also nominate a midwife to be on that panel. So the think tank for the meeting that led to the roadmap actually involved a midwife in terms of organization and the conceptualization behind it. And when it came to the meeting itself, out of that 130 stakeholders, I cannot count the number of midwives who participated in various discussions that led to the document that we developed. In terms of implementation, there's a lot of roles for midwives across those 4 strategic areas. I said research initially. There were 15 research questions, top priority research questions that were agreed at that meeting. And even part of some of those research questions are already been answered, and some are still in progress. But we were able to, at least one of them is around the early diagnosis of postpartum hemorrhage and use of treatment bundle. That particular research just got finished sometimes earlier this year. It was implemented successfully with the inclusion and participation of research midwives. And there are several others like that. But very importantly, the implementation component of the strategic area, especially as it has to do with training and supervision of frontline healthcare workers. So throughout, if you have the time, I would encourage you to read the roadmap. Every aspect of that roadmap cannot be successfully implemented without the midwives.
So centralizing the role of the midwife seems to be one of the core pillars of this roadmap.
Certainly, yeah.
Absolutely. And with that, I think it's a perfect moment to move on to Maya, who is a midwife, who's traveled to be with us today from Indonesia. Maya has been responsible with her community health centre in actually eliminating maternal mortality from 2015 until today. You created, I believe, and I think you'll tell us more about it, several WhatsApp groups that ensured that pregnant women were seen regularly, that medical teams were available, and that there were agreements that to ensure that women in labour distress could be transported to a high-level facility. It's an incredible, I think, achievement. What lessons can you share with us in the global community about how it is the power of this community-driven approach has been adopted, you've adopted to really solve this complex problem, using quite simple solutions and costing practically nothing in terms of resources. What do leaders need to do to empower midwives like yourself?
Terima kasih Claire atas pertanyaannya. Saya rasa keberhasilan untuk menurunkan angka kematian ibu itu tidak hanya saya sendiri, tapi tim work yang sangat baik di kami. Ada kerjasama baik dari masyarakat sampai ke pemerintahan, juga teman-teman yang lainnya untuk mendukung agar tidak terjadi angka kematian ibu.
Thank you so much, Claire, for this opportunity. For me, actually, the success in reducing maternal mortality rate, it's not just my own effort. Of course, it is also a teamwork between us, midwives, and all of the health resources within the village, all the mothers and the community.
Ya, karena ketakutan terbesar kami adalah bila terjadi kematian ibu dan karena terlambat penanganannya.
Because our biggest fear and anxiety is the death of mothers that happen because of mistreatment during delivery.
Ya, dari sebelumnya proses perujukan yang berbelit-belit, akhirnya saya di forum rapat IBI, di Rakernas IBI, saya mengusulkan bahwa harus ada gerakan yang nyata, bahwa angka atau risiko tinggi ibu hamil itu tidak berhenti di kita. Tapi kita bagaimana supaya ibu hamil ini bisa segera sampai ke rumah sakit. Untuk itu saya usulkan untuk membuat WhatsApp group.
So, before all of this, during one of the national meeting of the National Midwife Association in Indonesia, I expressed the importance that this kind of implementation to prevent HPP should not just stop between us midwives, but it should also go all the way to the regional and the national level. And because of that, I decided to create that WhatsApp group.
Dengan adanya WhatsApp group ini, kami namai Jamaica. Nah, ini bisa mempercepat akses kami untuk perujukan ke rumah sakit yang selanjutnya.
With this WhatsApp group, we have our own names for it. Our goal is that we could easily transport or communicate the transport of these mothers to the hospitals that have enough resources to make sure safe delivery.
Untuk itu diperlukan jaringan komunikasi yang juga bagus, jadi kita bisa berinteraksi dengan yang ada di rumah sakit, juga berinteraksi dengan teman-teman sesama bidan, karena bila ada risiko tinggi yang sedang kita tangani, kita akan memanggil teman-teman yang ada di grup itu untuk datang membantu, sehingga angka kematian ibu bisa dicegah.
For that, we do need this WhatsApp group so we can have good communication network, so that not only can we interact with the mothers who are pregnant, mothers who are about to deliver, but also to the other midwives, which I identify as friends, and we can communicate to them when we do need extra help during the delivery of babies, or we do need help to transport them to a better health facility.
Ya, selain itu juga yang diperlukan bidan agar bisa menurunkan AKI, adanya pelatihan, juga ada pemberian fasilitas peralatan medis yang lebih modern. Jadi masyarakat lebih percaya lagi kepada kita.
Aside from that, what midwives need are also training. We would really appreciate some more training and also more modern medical facilities and tools in order for the people and the communities to have even more trust in us. That's it.
Thank you so much. And I guess just to summarize the three interventions so far, and I think starting, Maya, with you, the real essential importance of hearing midwives' experience and knowledge at the local level, and thinking about how that can be scaled up, and also using technologies. So as new technologies come in, I think we can find more innovative ways, as you have done, in adopting them and communicating. So thank you for that, and I guess that really does inform what you were saying, Femi, about your stakeholder engagement and how important it is to use that knowledge and practice from midwives who are doing this day in, day out to inform guidelines out of the WHO. And I think then finally, obviously ensuring that gets onto the global health agenda and that this issue doesn't slide back down again. So yeah, summing up those three. Perhaps now I can turn Shirin again to you for a second round of questions. It's interesting to think about the role of men here, and this being an issue associated with people who are giving birth. To what extent do you think, slightly provocatively I suppose, if this had been an issue that impacted men more broadly or more directly, that it might be prioritised differently? So a good old gender question there.
Well, this is a difficult question to answer. So obviously we wouldn't know for sure, but there are indications that that would be the case. If you would speculate, looking back at the history of medicine and research and broader health agenda, we have seen a trend that issues that are related to women's health and women's rights have often kind of slided down into the global health priority agenda. And it is just perhaps more in the recent couple of decades that has been really drawing greater attention to the specific needs of women and women's health needs in a broader women's rights agenda, which I think is also important to highlight, that the health is really not disconnected from the broader right issues. And also a greater acknowledgement around the intersectional gender components and the gender dimensions in the broader research policies and programmatic implementation of the services that really highlights how paying attention to the differential needs and experiences has a benefit for everybody. So the issue of trying to bring in a gender lens is not only to kind of perhaps just rectify the past disadvantages that women have faced historically, but also bringing a benefit to men's health and the broader society at large.
Thank you, and thank you for raising intersectionality as well as a very key component to understanding the gender dimensions of postpartum hemorrhage. Thank you. Femi, maybe if I turn to you now, you've talked a little bit about this, the roadmap. One of the difficulties, of course, is always about gaining consensus among diverse stakeholders. Can you tell us a little bit more about that in terms of the process? And also how the WHO, what mechanisms it has, or how is it able to hold stakeholders accountable to this commitment?
Thank you very much. It's really hard to put one item to what made the roadmap development successful. However, I could maybe lay my hands on 4 things. First of all, in terms of context, postpartum hemorrhage is something everybody wants to do something about. So it wasn't really difficult finding the audience and attracting people around the table. But in terms of the process, we followed a WHO process of engaging stakeholders and prioritizing issues, building consensus. We started by having a steering committee of 18 people, as I mentioned, ensuring that this was geographically balanced in terms of the selection, gender balanced, right expertise from innovators, industry experts, implementers, NGO, women groups, representatives, making sure everybody's voice who needs to be there is around the table right from the start. And then when we had the meeting, before that meeting, there were lots of engagement of the stakeholders that were going to come to that meeting. So we ensured that there were surveys that we conducted, like a research prioritization survey, implementation barrier survey. We engaged all of these people. So people already saw themselves and engaged in that conversation before the 3-day meeting. The other important component was transparency. So there was no pre-arranged or pre-thought out kind of where we wanted this to land. We had a dream, we want everybody to agree. That was the main thing that we were after, and it was clear to everybody. So when we got to Dubai and we're having those sessions, people could see that there were times when things needed to change. So even though we agreed on a couple of things, following newer discussions, immediately we changed it and we all agreed. So there was nothing like, oh, this is where we're going to stay or this is what we're not going to do. So I think the transparency of the entire process, from the beginning through the end, and even after the summit, we continue to engage regularly. That really, demonstrated to people that it is not just about, what WHO wants to do. And very importantly, funding. We were lucky that 2 of our main funders, the MSD for Mothers and Gates Foundation, provided a lot of support. The meeting, you can imagine if you go to a 4-star hotel in Dubai and bring 130 people, that in itself made it to be possible. And part of the incentive for actually bringing those people was that if you don't participate in all of the background work, you're not coming to Dubai. And people wanted to come to Dubai. So in a way, everything just sort of worked together in that regard. In terms of how WHO wants to hold people accountable, I think one thing that we've been saying since the roadmap was published, and I want to stress that fact again here, it is not a WHO roadmap. It is a roadmap for postpartum hemorrhage, or the roadmap that was developed by everybody. So we all have a role to play in terms of holding ourselves accountable. What WHO has done is to prepare the roadmap. This is the journey to get to 0 preventable death from postpartum hemorrhage. How we do that, everybody can see themselves in all of those strategic areas. And the idea is we set up what we call accountability platform. where you can see all of these key activities and milestones set up from now through to 2030. Whatever you want to do, we want to see where that fits in the roadmap. And therefore, you make your commitment. We cannot really say, we cannot enforce you to do it, but people can see that you have committed to something and you make it happen. So I think collectively, it's very important for people not to say, oh, it's WHO roadmap, so WHO has to get everything done. No, there are just few people in WHO working on postpartum hemorrhage. But the larger community is much bigger, much stronger. People like Maya, people like, Metin, myself, we have colleagues who are also, pitching in different areas. So it is more about how do we hold ourselves accountable and how do we hold the international community accountable to ensure that we realize the goals that were set by all of these stakeholders.
Can I take the opportunity to ask a very quick follow-up question, a technical question? I guess when you produce the roadmap, who is the intended audience? Who do you hope will pick it up and take it forward?
The intended audience reflects the stakeholders who were invited, actually reflects the intended audience. There is a call to action in the last chapter of the roadmap that calls on different stakeholders what they need to do. So women and women's groups, donor agencies, implementers including non-government organizations and civil societal organizations, professional associations, so FIGO, ICM, national professional societies as well, the research community. So everybody has a role to play. When you look at those four strategic areas, there's something for everybody to do. And there's a separate chapter on call to action on what each group should do to ensure that the goals of the roadmap is realized.
Thank you for clarifying that. Maya, if I may turn to you again. As a midwife, what do you think are the political priorities to end maternal mortality from postpartum hemorrhage?
Ya, untuk mengakhiri angka kematian ibu secara politik, yaitu adanya ikut turut campur dari pemerintah agar adanya anggaran bagaimana supaya AKI ini bisa selesai. Terus kemudian edukasi ke masyarakat juga penting untuk mendapatkan pelayanan yang sesuai dengan standar yang diberikan pada ibu yang beresiko.
So to end the maternal mortality from HPP politically, what is very important is for the state to get involved in providing enough funds for the midwives to work with, and also education for the society and of the people regarding this issue is very important.
Kemudian untuk pemerintah itu diharapkan memberikan jaminan kesehatan untuk masyarakatnya, terutama pada ibu yang hamil. Jadi semua ibu hamil harus mempunyai jaminan kesehatannya.
It's also very important for the government to give a social health care guarantee, most especially for pregnant mothers and mothers who are delivering babies.
Dan tentang cara pengurusan tentang pemberian asuransi juga jangan berbelit-belit, semuanya diberikan, semua ibu hamil wajib diberikan.
Specifically, it is very important to ensure that the administrative process or procedure for mothers to gain proper, adequate health care for safe delivery is not complicated and is guaranteed.
Yeah.
Yeah, health insurance.
Yeah.
Yes.
Yeah. Selain itu ada gerakan masyarakat juga perlu, misalkan gerakan di desa untuk dana sosial bagi ibu yang mengalami kesulitan ekonomi untuk dia agar pada waktu perujukan dan selama mengalami resiko dia juga terjamin dengan adanya dana swadaya dari masyarakat seperti jimpitan.
Community level movement regarding this financial aspect is also very important, such as social fundings or some sort of social insurance for economic troubles that may be experienced by mothers and the risks and the health risks that they carry after the delivery of the baby. In my case, there is a social community fund within the village where mothers can access in order to get additional health care for their recently delivered babies or themselves.
Ya, jadi kadang masyarakat yang tidak mampu itu kebutuhan pada waktu terjadi perujukan itu tidak hanya tentang menyelesaikan kesehatannya, tapi juga pada waktu dia sedang mengalami kesulitan sehingga pada waktu pembiayaan yang di luar itu bisa tertangani.
So this social fund is very important, and it's not only, and it's offered to all mothers who are not able to afford things even outside of the health dimension, but outside of it and their social welfare, basically during the delivery and after the delivery of the baby.
Kami juga mendorong ibu hamil untuk melakukan ANC rutin secara gratis dan pemberian obat-obatan juga suplemen secara gratis. Itu dengan posyandu ibu hamil.
We also encourage mothers to pursue antenatal care and also further care after the delivery for free within the village health posts.
Dan pada ibu hamil yang mengalami masalah gizi dan anemia, itu biasanya diberikan PMT, baik dari Dinas Kesehatan maupun pemerintah daerah, dan juga di desa kami juga ada.
So for mothers who have blood-related risks like anemia, they're also given extra supplements and foods that could ensure that they get proper level of nutrition.
Thank you. Thank you so much, Maya. Really important to hear about the role of social protection, financial protection, and the avoidance of out-of-pocket expenditures at these critical times. And that's good to know about the community-based funds for this that really do have a significant impact. And I'm thinking about universal health coverage and the ways in which that has to be part of, postpartum treatment needs to be part of universal health coverage and access to affordable quality care. Shirin, I think you had another comment to make if I judged your eye contact correctly.
More actually a question, and thank you so much. This is such an impressive example of how women's engagement and leadership can really have positive impact. And thank you for raising the issue of economic empowerment, which I think you mentioned as well are very important. My question is also, have you observed any positive spin-off effect of this into the broader issues of gender equality and women's empowerment in that community? And I also have a question to Femi as well, and see how does the roadmap also are embedded in the broader issues around gender equality as well as women's economic empowerment as a key determinant of particularly perhaps this specific topic.
Iya, di desa kami ada PKK, jadi itu perkumpulan dari ibu yang sebagai ketua ibu PKK, itu ibu kepala desa, kemudian dari warga itu, para perempuan itu dihadirkan. Jadi kegiatannya selain ada arisan, biar menarik, kemudian ada edukasi juga. Kadang kita juga selain memberikan edukasi tentang kesehatan, ada juga tentang bagaimana pemberian makanan yang terbaik untuk anak-anak dan keluarganya, juga bagaimana cara mereka menangani permasalahan yang ada di keluarganya.
Okay. So in our village, we have something called PKK, which is an association of women led by the head woman of the village. In there, we have this concept called arisan, where you kind of get together and become closer to each other through the practice of collective fun. And we also have education programs during these meetups that we have. And yes, sometimes we have education regarding health. We have this discussion regarding health. But also aside from that, we also have education pertaining to the nutrition that is required for children and for the families. And also some discussion session or education session about any household issues that we might face as women.
Thank you. And Femi, would you?
Thanks, Shirin, for that question. I think integral to preventing maternal morbidity and mortality is the ensuring that gender inequality is addressed, and not just for postpartum hemorrhage. I think a key social determinant of maternal health is that, and especially because things like postpartum hemorrhage, preeclampsia and the likes are more or less manifestations of those broader social determinants, especially gender inequality. As you know, several of these are, reflections of gender roles of women in the society. So one of the critical barriers that was identified within the implementation strategic area of the roadmap is the weeks, I can't remember exactly the wording, but the status of women in the society. And part of the solutions that were preferred by the stakeholders was something around economic empowerment, improving social status of women. So whatever strategies that could be locally engineered to ensuring that that is addressed is a critical part of ensuring that postpartum hemorrhage mortality and morbidity are reduced. Usually many of these strategies, they tend to be slower to be impactful, but their impacts are certain. You have to sort of think of a longer term strategy to ensure that that is done. Women's education, making sure that there is social incentives and security to ensure that we reduce gender inequality.
Thank you. And that really sort of speaks to the need for us to join up the SDG 3 and 5 together, health and gender equality, as mutually beneficial goals to move forward in health and women's equality. I'm going to ask another question, just taking us on to a little bit about political will. But before I do that, I just want to give you a moment, the audience online and in the room, to think about some questions, because after this round, we will then move to a Q&A session. So have a moment to think about some questions. But finally, I think I wanted to ask about political will, particularly to Femi, in terms of, we've talked about the economic component, we've talked about the need for local knowledge and practice. At the global level, we often need to think about getting that traction at the political will level. I wonder if you could speak a little bit more to that and how we can garner further political will to make this a priority. And Shirin, I don't know, and Maya, if you wanted to comment on that, you're welcome to.
Yeah, certainly. I think Metin also mentioned it during when he was setting the scene for this talk. Probably the most important factor to make anything work is the political will. And I was reading on Twitter a couple of days ago, and there was a message that somebody sent that really struck a chord with me. And that was, they were talking about health and politics. And there the person said, health is a political subject. And that is true. You know, it's not just maternal mortality, it's not just maternal health or postpartum hemorrhage, health in general. In places where the politicians are interested in ensuring the health of the people, they may put the right allocation, budgetary allocation to health, and you see everything trickles down into benefits for the populace. Whereas where the priorities are different, then the outcomes and the impact on the populace is also on the other side. Political systems in general, it's what you could call a super determinant of maternal health. You appreciate the impact more with maternal health than many other areas of health. And so when, you know, as a clinician, you're seeing a pregnant woman or a woman who just delivered bleeding, you know, if you trace everything back indirectly, the political system or political configuration in that society has a role to play. And politics, you can't really separate that from conflicts and strife and all of the things going around the world right now, where you're having impacts on health systems and ripple effect on the outcomes for women in general. And that sort of brings you to, I'm sure we're all familiar with the famous quote by Professor Mahmoud Fatala, who just passed away about 2 weeks ago, who said that, you know, women are not dying because of diseases that we cannot treat, but they are dying because the society has not considered their lives to be worth saving. And that's, I mean, it's over 20, 30 years ago that he said that, but it still resonates today because of the way things are going, you know, in the world. And what other question did you ask me? Sorry, I just...
Oh, maybe the role of ministries as well.
Okay.
Yeah.
So the Ministry of Health have a central role to play. So in development of the roadmap, we ensured that we brought them around the table. We invited representatives from about 20 ministries of health, looking at, I think, top 20 countries with the highest burden of maternal mortality, and by inference, postpartum hemorrhage maternal mortality, for them to be around the table. They are extremely critical in ensuring that those 4 strategic areas that we itemized in the roadmap are successful. For research, for instance, they need to build local research infrastructure, support innovations within the countries to ensure that we're able to respond to critical questions around postpartum hemorrhage. My colleague mentioned at the beginning of the session that only 2 drugs have been tested on postpartum hemorrhage in the last 10 years. It's actually the last 30 years. Yeah, so it's you know, the investment is quite poor, but even when you get to countries, sometimes the Ministry of Health have an important role to play to ensure that there's local participation in global research. And in terms of, and still talking about that as well, we found situations where ministries of health wants to replicate studies that have already been done at a global level, where the evidence is already clear. They say, oh, we were not part of that study, let's do it again. And that's a misuse of, you know, little resources that they have. But the ministry also have an important role to play in terms of guidelines. Metin mentioned at the beginning that there's a disconnect between global evidence-based recommendations and what people are doing on the ground. This is the central role of the ministry in terms of adaptation and adoption of, you know, global evidence-based recommendation and ensuring that they are scaled up at the local level, from the district down to the hospital level. And thirdly, implementation. They are central to implementation. Metin mentioned weak supply chain, procurement chain. In some countries, it's just all over the place. You know, people are bringing in quality, unassured medications. And especially with postpartum hemorrhage, I'm sure Metin also mentioned some of those. Cold chain system is not good enough. Training and supervision, hiring of competent healthcare workers is purely the role of ministries. And financial incentives, ensuring that there is health insurance that can enable people to actualize the goals in terms of health. It's quite critical. And one of the things that the stakeholders also profiled in the roadmap is that user fees should be removed where possible, especially for emergencies, as it relates to maternal health. In places, I'm from Nigeria, in parts of Nigeria where there are no user fees for maternal health, maternal mortality, plummets. Whereas in other places where you have to pay for every little thing, women continue to die. So, and this is all within the hands of the ministries.
Thank you. There's some really, really important points there. And actually thinking about the accountability question earlier, there is a role clearly for ministries of health in seeing that these types of guidelines and roadmaps are implemented all the way through to the local level. Maya, would you like to comment?
Dari segi politik, dari desa kami ada dana desa, nah itu dipergunakan untuk kesehatan bagi ibu hamil, kemudian bagi warga, juga ada ambulan desa. Jadi dengan adanya kebijakan dari pemerintah daerah kami, sehingga desa-desa itu mempunyai ambulans desa.
So from the political point of view, I want to give an example from our village. Not only do we have this village fund that is accessible in addition for the mothers within our village, but we also have a village ambulance that prior to this was not available, that we lend to the neighboring villages around us.
Saya harapkan jumlah bidannya saja yang ditambah, karena seperti di Kecamatan Trawas, saya itu membawai 2 desa, kemudian merangkap sebagai ketua PONET di Puskesmas Trawas. Jadi pekerjaan saya double job.
So I just hope that there is an increase in the number of midwives, because in my sub-district, Trawas sub-district, I am taking care of 2 villages while also holding another position in the village hospital, and basically I'm doing double job as of now, and we really need more midwives and other helps.
2 desa.
Yeah, for 2 villages. 6,000 residents population.
Absolutely. So, health workforce resources are desperately needed in order to address maternal mortality. Absolutely. Sharon, do you?
I can just add in terms of the political will. I think, particularly now we are in a particularly perhaps challenging political landscape where it's very divisive and polarized in terms of, gender in particular. There's obviously a growing momentum of an acknowledgement of all these gender-related issues in health, in politics, and so on and so forth. And at the same time, we have the other side, where there is a really strong backlash against women's health and women's rights. So in that sense, I think sometimes issues of health can have a dual role. Partly addressing the gender equality issue can be a very important determinant of health and advanced health outcomes, but sometimes also using health as an entry point to advance gender equality could be a very smart approach to really address the broader issue. And it's also important to see, I'm always impressed with the example that Maya has, how such a focus on addressing a health issue can have such a positive effect on broader health issues, on broader gender equalities, broader women's empowerment. So it really has a positive impact. And in the context of now ever-changing climate and environmental issues, the problems will only grow. So it really needs a stronger political will, which hopefully can also be inspired by the community and the advocacy that is being generated as well.
If I could just add a point, I think in terms of what we need to do about it, we need to appreciate that focusing on biomedical causes of mortality alone is not going to get us to where we want to go. We have to think of broader strategies to be able to achieve that. And there's a concept called health diplomacy. I'm sure some people will be aware. I was in a meeting like 2 months ago now on Human Rights Council, the 54th meeting, where member states were deliberating on preventing maternal mortality and morbidity and human rights, and one of them was making that proposition. And I was totally blown away by the discussions that countries were having. I was surprised that in 2023, there are countries that still felt that contraception has nothing to do with postpartum, with maternal mortality. Safe abortion, we don't want to hear it. So we have to think about the intersection between sexual and reproductive health and rights, and how that connects to preventing maternal mortality and morbidity, because there are countries that don't want to hear this. So there's, push and pull. And if you really want to solve this game of numbers and political debates and ideologies, you need to meet them midway and find a diplomatic way of bringing them around the table. Otherwise, we can do all of this forever. We're not going to get the result that we're looking for.
I thank you very much for bringing attention to that, because that resolution going through at the Human Rights Council just a month or so ago really did expose the geopolitics of the polarization of gender and the role of gender in negotiations, which is very problematic at the moment. So yeah, thank you for bringing attention to that. I would like to take the opportunity now to open it up to the floor. I know we have some online questions, which I'm going to field from Ellen. But if we have anything, if I could begin in the room, if we have any questions to begin with. I can see a couple of hands going, oh, I can see lots of hands going up. Perhaps we'll start at the front and then work backwards. Thank you. Here.
Hello, good afternoon. I'm Sarah Rashwan from Concept Foundation. Firstly, thank you all so much for such a great and insightful discussion. I have an open question to the panel. So reflecting on Maya's success story, how can we as the global community improve our awareness of locally led initiatives that have resulted in reductions in maternal mortality in order to help integrate the global PPH recommendations not only to the local context, but to existing initiatives that have worked?
Thank you. Maya, would you like to respond to that question?
Yang kita perlukan adalah bagaimana kita menggerakkan wanita-wanita yang ada di sekitar kita, mulai dari usia masih remaja, kita berikan pendidikan yang baik. Kemudian di tingkat wanita usia subur juga kita berikan pendidikan agar dia menyadari bahwa tentang reproduksi ini penting bagi dia. Bagaimana dia mengelola agar kehamilannya di usia yang sehat, dengan jarak yang sehat.
Okay, so more so in the community level, there is an importance or a priority to mobilize women up from teenhood and up until womanhood to recognize how reproductive health and maternal health is important, because this is not something that is well communicated or, in lack of a better word, educated to within the community level.
Di kami juga selain ada gerakan untuk di usia sekolah itu minum tablet tambah darah. Kemudian pada waktu dia nanti akan menikah juga ada pendidikan tentang bagaimana dia di masa menikah pemeriksaan dasar pada waktu akan menikah juga diperiksa. Jadi ini membantu sekali ibu yang akan calon ibu untuk mendapatkan kesehatannya. Jadi dia tahu bagaimana apa saja yang diperlukan untuk menghadapi kehamilannya.
Aside from that, in the community level, in the village level, we do have a program to encourage young women to drink these supplements to ensure that they have enough amount of blood for anemic women and also non-married women in the villages. They also get an education about what they can expect after marriage in terms of the kind of health care that they're able to access, regular health checkups and whatnot, to ensure that they know what they're, what they have, what they're able to access.
Jadi itu juga sebagai inovasi di puskesmas kami, caping mas, calon pengantin bermasa depan emas, dan ini juga menang tingkat provinsi.
Yeah, so that's an innovation from our village. This preparation, this kind of like education model for the soon-to-be mothers or soon-to-be brides. It's called Chaping Mas, and it recently also won an award for our village for this reproductive education between soon-to-be mothers.
Thank you very much indeed. Turning again to the floor, maybe I can take a couple of questions, absolutely, at the front there, thank you. And there's another one behind. We'll maybe take the two together so we can have a response.
Good afternoon, and thank you for the very informative session. So my question is about around the role of social protection in improving maternal health. So I'm talking this from my experience in working with a program which aimed at reducing low birth weight of children in India by giving a nutrition-sensitive cash transfer to the mothers. Like we provided cash transfer to mother on monthly, and then empowered them to sort of access to food. So my question would be like, from WHO's perspective, how can we integrate these kind of social protection, or how can we integrate social protection as a strong strategy to improve maternal health, and what are the potential challenges you anticipate in doing so? Thank you.
Thank you. And I think there's another question to the gentleman to the behind. We take the two questions together before we go online.
It was actually more of a comment as a WAM. I don't know if you know what a WAM is. It's a white-haired aging male, I regret to say. I'd like to follow up on a couple of things that Femi pointed out. And his last comment, we can do all of this forever. The biggest problem, we have been doing all of this forever. And I would like to recommend to Shireen, for example, that you go back and look at the person that Femi mentioned, Mahmoud Fatallah's presentation in 1987, when the Safe Motherhood Initiative was being formed, called Why did Mrs. X Die? Why did Mrs. X die? The reasons he gave all related to poverty, gender status, etc. And they all exist today in 2023, almost to the same extent, which is a very, very sad comment. We haven't done very well in meeting the Millennium Development Goals, and now we've got this incredible SDG of reducing maternal mortality to 70 per 100,000 lives. How do we do it? And I'd like to ask Femi, which bits of the roadmap could be weaponized, to use a modern terminology? I mean, we have women's groups in every single country you go to, women's groups on the ground, such as Ibu Maya has been talking about. How can they be really informed and utilized? I mean, I feel very passionate about it. I've sat in a village in Papua New Guinea, and the chief of the village has said to me, oh, we lost 15 women last year because they were bleeding heavily during delivery. We can do things, we've got solutions. We've even got simple drugs like misoprostol that we can give to villages like that. It's the things that Metin can be talking about. But what can be weaponized, Femi? What are the key bits? How can we use people at the ground level like Ibu Maya, and how can we really mobilize something that we've been talking about for 50 years?
Thank you. Femi, would you like to begin? And then perhaps Sharon and Maya, if you also have some comments to both the questions.
Sure. Let me start with the last question, because that's something that we've also thought about which part of this roadmap should be the arrowhead for implementing change. And when you look at all the components, as you said, many of the things that we're doing now are things that we've been doing for a long time. But at the same time, we have to appreciate that the world has changed between 1987 and now. Some of the things that Shireen spoke to about, nationalism, extremism, political views, divisions in the countries, they're affecting how we look at sexual and reproductive health and rights, and by inference, how we look at maternal health. So part of the stagnation that we saw in maternal mortality is a reflection of some of these changes that probably got even worse from 2015 until now. And we don't still know where that is going. But if you look at postpartum hemorrhage roadmap, there are 4 key elements that I spoke about: research, norms and standards, implementation, and advocacy. I think the strongest part of all of those is advocacy. You and I understand what postpartum hemorrhage is. We know the definition, maybe clinicians do, but when you ask women who are pregnant themselves, they have no idea. They know, should I bleed a little bit of blood or lots of blood? And the politicians, the parliamentarians are also not aware. And one of the motivations for the postpartum hemorrhage roadmap development was actually that, because we've spoken for a long time about maternal health as a broad term, that it gets lost in the conversation. So we say maternal health, everybody thinks it's pregnancy. Oh, the woman, next to my house just delivered. Everything went well. So there's no problem with maternal mortality you're talking about. And then we said, you need to speak the language that people can understand. Malaria, for instance, HIV, for instance, has a lot of investment because people understand that one disease condition. And then we said, when you say postpartum hemorrhage, when you say preeclampsia, it should strike a chord with the parliamentarians, with the politicians. And therefore, using civil societies, using women's groups, using people who give voices to those who don't have a voice in the countries, and making this really loud and clear through whatever medium that they're able to do that, will go a long way in people getting a little bit more aware that people are really dying. I conducted a study in Nigeria in 2012, 2013, where we looked at over 42 hospitals. And it was shocking when we started reporting maternal mortality happening on a daily basis, because each hospital felt, oh, we only lost 1 woman this month. But at the same time, they're losing women all over the place. So when we started reporting it, everybody was like, wow, I didn't realize so many people were dying. But these numbers don't even get to the people that make decisions. So part of what we put in the roadmap is measurement. There should be a measurement platform at the national level to understand how many women are dying from postpartum hemorrhage. What gets measured gets done. So if you measure it, you have a target. Oh, maternal mortality from postpartum hemorrhage is X number on a daily basis. How can we reduce that to 50%? What do we need to put in place? So these are all and if you make that number known to everybody, if it gets out in the newspapers, for instance, people are going to take actions. Politicians don't take actions if nobody's talking about these issues. So social media, whatever media is out there to elevate the profile of this condition will go a long way in improving the overall profile of women. In terms of social protection that my colleague spoke about, is quite important. It's not the easiest thing to do because it's also tied up to political will in every country, and it's dependent on several other factors. So while it might work in some areas, even within India, I'm sure it's not working everywhere. But generally, we sort of, try to promote social protection strategies where that is possible. I'm going to stop there because I see there's
Thank you very much.
Well, thank you so much for that comment. And yes, I agree with you, and I'm very familiar with Mahmoud Fatollah's, and may he rest in peace. I wasn't aware he passed away. And yes, and I think it brings us back to the first question, is this a priority? Because we have done that forever and ever. And I will really come back to the issue that of the gender equality aspect, because a little bit, this is really my personal opinion as well, that a lot of this work that is happening in terms of women's empowerment, gender equality, addressing the kind of really underlying determinants of health which these constitute, is still done by women without any resources. It is coming down to the lack of investment. It's yet another unpaid care work that we do in institutions, in society, and we cannot just continue doing that as a pro bono basis. These are professional works related to professional issues, and really these groups need to be resourced and supported, both politically, socially, but also financially, to be able to really drive a change. So as long as we're not taking these issues seriously and not prioritizing this as a bigger part of a broader women's health agenda and women's rights agenda, and we don't invest in them, we will continue just creating reports and roadmaps and relying on women's goodwills.
Ya, untuk itu juga memang diperlukan seperti pengangkatan bidan di daerah lokal. Jadi misalkan seperti yang diutarakan tadi di Papua, nah di Papua juga harus banyak mengangkat bidan dari daerah Papua, sehingga masyarakat itu tahu, petugasnya juga mengerti apa yang mereka mau. Jadi pada waktu penanganan juga mereka itu lebih percaya dengan lokal, karena ada bahasa, tradisi yang bisa mempengaruhi kebijakan seseorang untuk mendapatkan pertolongan dalam hal persalinan maupun kehamilannya.
Yeah, on top of that, for that we also need to, there's a very big important aspect that we need to address, which is to hire local midwives. Like, for example, in Papua, maybe we need to hire local Papuan midwives because they know what's happening in the local level, they understand that, and on top of that, they gain more trust from the community. They have a different, deeper understanding about the language, about that tradition, and this kind of trust is very difficult to come by from people outside of the community, and that's why there is a need to acknowledge the importance to hiring local midwives.
Thank you very much indeed for those really thoughtful responses to the questions. I think we're going to now move online. I think, Ellen, you have a few questions from our online participants.
Yeah, the online audience is exploding. The chat box is a little bit on fire. So I'm going to group a couple at a time, if that's okay. So one question for Femi comes from Suri Moon, the director of the Global Health Center here at the Graduate Institute. And Suri asks, what does international investment in maternal mortality look like over the past few years? And what are the prospects for the next 5 to 10 years? Do funders seem to believe it remains a global health priority? And a second question from Suri is for Maya. What influence do WHO guidelines have on your work?
That's a very good question regarding investments in maternal health in general. And I think Metin touched a little bit on that. While I cannot provide an exact figure in terms of maternal, the millions or the billions that's been spent on maternal health, compared to what we had 30 years ago, if you look at, there is a slide, unfortunately I don't have it here, where if you compare the likes of the other disciplines or other areas like malaria, like HIV, while the investment for those other conditions have increased exponentially over the last 20, 30 years, for maternal health, it's remained more or less the same since, the time of Safe Motherhood, for instance. So if you ask me about the global outlook, I think maternal mortality is something everybody wants to prevent and avoid, but not enough investment is being put in this area. And that's part of the problem, from research through to implementation. I was joking with some of my colleagues the other day. I mean, give me $1 billion. I'm going to bring down the maternal mortality level in 2 years. We know what to do, but you also need the investment to help you get there. And right now, the outlook is getting better, but it's far from being ideal.
Thank you. So $1 billion we need. 2 years. We need to get fundraising. Maya, did you want to comment on the guidelines and to what extent you use them in your work?
Untuk peta jalan yang dari WHO itu untuk di level saya masih belum sampai. Tapi kebijakan-kebijakan sebelumnya itu sudah kita jalankan, seperti kita dalam menangani ibu hamil yang berisiko, terus kemudian kapan kita harus merujuknya, terus obat-obatan apa yang harus disediakan di tempat kita, itu kita jalankan sesuai dengan petunjuk dari WHO.
So the current roadmap from WHO has still not reached to my level yet, but previous policies from WHO has been implemented within my level, such as taking care of the procedure of taking care of at-risk mothers, and when should they receive those specific healthcare needs, and also what types of medication should be used. But for the roadmap itself, it has not reached down to my level.
Thank you. We have some more questions, I think, online.
Definitely. Oh, it's so hard to choose. They're all so good. This is maybe a question for Metin. Laura is asking, in addressing maternal mortality linked to hemorrhagic complications, including issues such as placental maldispositions and fetal macrosomia detectable through routine prenatal care, how can we improve access in rural areas, extend ultrasound benefits to remote regions, and leverage technology for proactive management, ensuring preparedness for childbirth?
Big question.
Well, thank you for that question. I think Femi may be better placed than I do, because they obviously issue and update antenatal care recommendations at WHO. We have been looking into ultrasound as a specific technology for a number of projects, and this is one area where there's huge technological advances in terms of using artificial intelligence, and there are actually devices where you don't even have to be a healthcare provider. Women can just blindly use it on her own abdomen. But these are all at the moment at research level. So I think this area will probably advance quite fast in the next couple of years. At the same time, I think technological advances should not sort of override the basic healthcare needs that we are striving towards in terms of having a midwife at the time of birth and having proper antenatal supplements and so on. So I think in terms of how we approach these, probably their public health significance should be the driving force in terms of how we prioritize them.
One more?
One more, and then
Yep.
final one.
Yeah, we're good on time. So Luciana, asks, I'm just wondering if we can give faces on this postpartum hemorrhage issues. Women who survive from this can encourage others, help the family to alert and be prepared, embracing husbands to also take part. Maybe there are already examples for this kind of involvement. And I'd like to bounce that a little bit to Maya and extend onto that something that Maya had described to me, that as part of the achievement of eliminating maternal mortality in her village, that the midwives also extended their work. They mobilized the midwives in the neighboring villages in the sub-district who have achieved the same goal. And one of the ways they did that was getting families to sign a paper that committed the family to allow midwives to transport a woman in labor distress to a next higher level facility, which is used to be about a 2-hour drive away 5 years ago. Now the roads are better. It's about a 40-minute drive away. Still enough time to bleed to death en route. But so these kind of scary midwives got together and they intimidated the population enough to sign things where people are afraid of signing documents. And then they knew they had a commitment. But it was also the midwives who were scared because if a woman dies, they're blamed. So what is the lesson from that for mobilizing beyond a village to a larger community to spread the same effect?
Ya, jadi di tempat saya itu kami mempunyai WhatsApp group. Jadi apabila ada misalkan pasien yang harus dirujuk tetapi tidak mau, kadang itu dia akan pergi ke desa yang lain. Nah, kita bicarakan di dalam WhatsApp group bahwa ada Nyonya A itu beresiko tinggi tidak mau dirujuk. Nah, nanti kalau dia datang ke tempat yang lain, bidan yang lainnya juga akan melakukan hal yang sama. Kemudian selain itu juga bila menolak dirujuk, biasanya saya minta tanda tangan. Jadi dia akan ada rasa takut karena bila ada risiko, dia sendiri yang akan menanggung akibatnya.
So, as I've spoken before, at my village, we have this WhatsApp group, and it is often sometimes the case, the patient doesn't want to be taken to a hospital for a safer delivery. Sometimes they would go to another village where perhaps the midwives would then force them to go to the hospital. But what we do at the WhatsApp group is that we inform the other midwives about there's this one mother who is trying to run away and they refuse to go to the hospital even though they need to in order to have a safe delivery. So when one of the mothers when the mother moves away, we let each other know. And when we do get a hold of the mothers, we make them sign this sort of document talking about all of the possible risks that could happen if they do not agree to seek help from a hospital. And that kind of instills some sort of fear as they sign it, and that encourages them to also go to the hospital instead.
Ya, juga apabila ada yang kita tangani tiba-tiba ada kegawatan, kami juga bisa memanggil di grup itu untuk datang ke puskesmas untuk membantu. Jadi sebelum kita lakukan perujukan, kita sudah melakukan penstabilan. Jadi kondisinya lebih baik sebelum pemberangkatan ke rumah sakit.
This channel of communication, this group is also important so that if there is emergency during the delivery, when we are taking care of a mother, we notify all of the other midwives so that they could make sure that there is adequate preparation being done in the hospital to immediately take in the delivering mother.
Jadi biasanya yang sering terjadi kasus HPP termasuk Jadi kalau ada HPP, kita yang jaga, kita akan memanggil teman-teman yang ada di sekitarnya. Juga misalkan ada bayi yang asfiksi, itu juga kita memanggil bidan-bidan yang ada di sekitar ini untuk membantu. Jadi kadang datang sampai 6 bidan untuk ikut menangani.
Sometimes what often happens, especially in the cases of postpartum hemorrhage during delivery, is that we would, myself as a midwife, we call on other midwives, also in the cases of asphyxiation of the baby, to come and help us during the delivery. So sometimes there are deliveries that would have up to 6 midwives in the room trying to help each other that were contacted and mobilized through the WhatsApp group.
Thank you so much, and for the detail of that response gives us a real sense of that lived reality. I'm mindful of time, and we also have some closing remarks from Eric Comte to come, but it sounds like we need a call to action for the 1 billion fund to prevent maternal mortality. So in the meantime, I'd like to thank my guests, and then invite Eric, if you'd like to come up. But thank you very much for a really good panel discussion. Thank you.
As a closing remarks, I'd just like to make some highlight about some ideas that very good panel. Thank you very much. So first, just this number, 70,000 deaths per year. So we don't realize exactly sometimes what it means. It means 200 people per day. And it means that during our session, maybe somewhere in the world, 8 women die from postpartum hemorrhage. It's just to give the importance of the problem. And we see that it's a problem of drug. We don't have enough really good drug. But if we don't have good drug, it's because it's a problem of research, it's a problem of investment. It was already said. But it's certainly also mainly because it's a problem of human resources. And we show the experience with Maya, and it was said by other speaker, that to have trained nurse, experienced nurse, and midwife, is really a very key point. And the experience of Maya was really interesting because they really show how with simple means, when the local people make a real empowerment, you can really get a very good result. And we say also women engagement is very key. We cannot address this problem without women and without a man, of course. And I think it's very important in Geneva. We have all the headquarters where we try to make a lot of job, but sometimes we are always a bit far from the field by definition. And it's very important to have people like Maya coming in Geneva just to speak and to speak about the direct life that and work that they are doing. But I think that also we can be maybe a bit optimistic because there is this roadmap that happened only in October. So it's very, very, really new. So, of course, there is a lot of roadmap that was done in the past, and you explained that maybe 20 years there is already some willingness to change, and no things change really. But as you say, maybe this roadmap can be good because it's really done with the community, with a different, large spectrum of organization, and it's this new method of that can maybe change the game. And in 24, on the roadmap, if we read, there is a call for proposal to conduct a new priority research. So I think it's maybe the next step to follow strictly. And in 24 also, we have in May the World Health Assembly. So I don't know if WHO think to put some resolution at this World Health Assembly in order to push the roadmap. But if it's not done in 24, it has to be done in 25. And we need to mobilize ourselves to put pressure on the permanent mission who are in Geneva to encourage to have this resolution. So thank you for all this panel, and I hope that next year we have good news. Thank you.
Well, thank you all so much for joining this event today and to this amazing panel. This has been so rich. I already, in 2015, I met Maya in Indonesia, in her village, and she told me this story, and I just never forgot it because I never heard it anywhere else in the world, wherever I've worked. And it's been a long time in coming, and in working with Anna from the Ministry of Health. So I'm thrilled. And I had no idea a year ago when I started planning this that WHO was starting this roadmap work. I had no idea. So the fact that it was just completed a month ago, I mean, maybe these are really good stars aligning signs that we're going to see some better picture in the future ahead of us, because I have felt really angry about this issue because it's just wrong and it just shouldn't happen. I want to thank everybody in our team today who made this happen, because to pull together an event, it really takes a small village. And that's our platform team, in particular, Bettina Zago, Jia Yang, Negar Mansouri, and a special thanks to Mentari Binar, who's a second-year master's student here at the Institute, who helped us to speak with Maya today so skillfully. In a moment, those of you online will be directed to a very short survey page. Please take a couple of minutes to answer the questions. The recording of the event will be available in a couple of days at ghplatform.org. And please subscribe to our newsletter and hear about all of our upcoming events. The next one is next Monday, on December 4th, entitled Psychedelics, Medical Miracle or Illicit Drug. So I'm sure that will be a very interesting discussion on a quite different topic. For those of you here in person, we invite you, please join us upstairs for a reception. Thank you, everyone.